All right. Good afternoon, everyone. And thank you for joining us for today's Lunch and Learn on rural pharmacies, an overlooked piece of the rural healthcare system. My name is Brandon Hofstad, and I'm the Community Economic Development Program Manager with the University of Wisconsin-Madison Division of Extension. And it is my pleasure to kick off today's webinar. Before we begin, I would like to thank the U.S. Economic Development Administration, the Wisconsin Economic Development Corporation, and the Wisconsin Department of Administration. Today's webinar was made possible in part by grants from the US EDA in support of the EDA University Center at the University of Wisconsin-Madison and from WEDC in support of the Rural Wisconsin Entrepreneurship Initiative. A few housekeeping items before we begin. Today's meeting is being recorded and final video will be posted on our website. I'll drop a URL a little bit later in the program so you can have access to it, and it will also be sent out via email following today's event. The webinar does have closed captioning if you require it. You can find that at the bottom, and it looks like someone may have already kicked it in. So if you need that, please feel free to use that feature. As a friendly reminder, please be sure to mute your microphones when you're not speaking. We will have an opportunity with today's presenters to engage in question and answer following the presentation. But if you do have questions during their presentation, please feel free to drop those in the chat. You can find that at the bottom of the screen, and either myself, Kristen Runge, or my colleague Todd Barman will be keeping tabs on the questions and comments. And if you don't feel comfortable sending it to the whole crew that's on or posting it to the entire audience, you can also send it to one of us in a private chat. And in just a moment, I'll turn it over to today's presenters. But before doing so, a little bit more about today's webinar. The focus of this will be on the pivotal role rural pharmacies play in providing vital healthcare services, especially in areas affected by hospital closures. The decline of independently owned rural pharmacies is a pressing concern affecting medication access and downtown vitality in many rural communities across the United States and in the state of Wisconsin. And here to share some insight on this issue are two presenters, my colleagues, Melissa Kono and Dr. Steve Deller. And I'll start with Melissa. Melissa is an associate professor in the Community Development Institute with the University of Wisconsin-Madison Division of Extension. She is the co-author with Steve on a recent publication, Rural Pharmacies, an Overlooked Piece of the Rural Healthcare Milieu. In addition to her community economic development work, Melissa provides training on election law and processes to election workers. Steve Deller is a professor of agricultural and applied economics at the University of Wisconsin-Madison and a community economic development specialist with Extension. Steve's work focuses on modeling community and small regional economies to better understand the changing dynamics in the economy, assess the impact of those changes, and identify local economic strengths, weaknesses, opportunities, and threats. And with that, I will now turn it over to our presenters, Melissa and Steve. The floor is yours.
Well, thank you so much, Brandon. Thank you for hosting and for organizing. And thank you to everyone for being here and for your interest in this topic. My colleague Steve Deller and I delved into this work a couple years ago to look at the impact that pharmacy closures have, particularly in rural areas, from a community perspective. And when we think about rural healthcare and access to healthcare, much of the focus and the headlines have been on rural hospitals, especially as these hospitals regionalize and close across the country. And even most recently in my area, the closure of Sacred Heart Hospital in Eau Claire and St. Joseph's in Chippewa Falls, and then the corresponding closures of Prevea clinics has been the main headline of our local news here in Western Wisconsin, because many people are concerned about what it means to lose a major hospital in our area. And this type of closure isn't out of the norm. This is a MAP project out of University of North Carolina at Chapel Hill that looks at the closure of hospitals in rural areas and mapping those closures. And so why this is important is that people living in rural areas are already at a disadvantage when it comes to healthcare access and health indicators. And a couple of these things are intertwined. For example, people who live in rural areas are generally at higher risk of disease and death than people who live in more urban areas. They're at greater risk of death from heart disease, from cancers, strokes, and unintentional injuries such as motor vehicle accidents. And think about if somebody's in a car accident in a rural area, they're often very far away from a critical care hospital. Rural residents also more likely to have multiple health conditions that can kind of compound a person's risk for serious death or a serious health injury or issue. Also, people living in rural areas often have greater risk for poor health outcomes. They tend to have higher risk factors like tobacco and alcohol use. Also, seatbelt use is less in rural areas, and all of these kind of combined to make living in a rural area more health adverse for people. And so we see this access to hospitals. You know, when people live further from a hospital or even just routine health care, it's hard. Their health is impacted. But what we haven't seen a lot of focus on is how an access to a pharmacy can also have detrimental effects to people's health. So Dr. Deller and I published a piece recently in Choices magazine about looking specifically at rural pharmacies and how they're kind of a overlooked piece of the rural healthcare, that we have access to hospitals. The access to hospitals is decreased, but also what happens now when a really key piece of healthcare, such as a pharmacy, is now also diminished. And so Steve put together some of the health outcomes across the urban-rural spectrum and some corresponding data. So I'll turn it over to him.
Thank you, Melissa. I think one of the things that when Melissa and I first started talking about this, the way Melissa came at it was really kind of a downtown redevelopment type of question. One of the things she noticed is that for many rural communities, those independent pharmacists oftentimes are an anchor institution in the local downtown, and they're going away. And that question kind of raised this broader issue that Melissa's been describing. But what we want to do here is to kind of actually look at what some of the data is saying related to health outcomes and health behavior. So what we're doing is that we're using data that has been collected by the Wisconsin Public Health School, the county health rankings that you may have heard. We're using some of the data that they've collected. And what we're looking at here is really kind of differences across metropolitan counties, non-metropolitan counties that are adjacent to metropolitan areas, and then kind of non-metropolitan remote. If you can think of kind of Dane County, Madison being a metro, Sauk County would be a non-metro adjacent, Crawford County would be more of a non-metro remote. These are just a handful of different types of indicators. And what we found is that there are statistically significant differences across these spectrums. Okay, for example, the percent of live births, low birth rates, tends to be a little bit higher in non-metropolitan adjacent. You see the same types of things in terms of average number of physically unhealthy days within the past 30 days is a little bit higher in non-metropolitan. The percent of adults reporting fair or poor health is relatively higher in both types of non-metropolitan counties. So there is some evidence here that rural health tends to be a little bit lower than urban health. Next slide, please. Okay. This is kind of more health behavior, if you will. This would be the percent of folks that are diagnosed with diabetes, age 20 and above. That you could say that that's a health behavior. Again, it's lower in metropolitan than in non-metropolitan. Poor mental health tends to be higher in some non-metropolitan areas. Teen birth rates really kind of jumps out as much higher in non-metropolitan areas. The obesity, again, it tends to be higher in non-metropolitan areas. And the percent smoking tends to be higher in non-metropolitan areas. Next slide, please. So generally, health outcomes are less desirable in rural areas relative to urban, but the patterns across non-metro adjacent and non-metro remote is less consistent, okay? For some indicators, remote rural is actually the healthiest of the three groupings. So while we can make a broad generalization that rural health tends to be lower than urban health, when we get into individual indicators, a little bit more detailed story comes out. Next slide, please. Now, the question then is access to healthcare. And again, what we're doing is that we're looking at a range of different ways of measuring access to healthcare. For example, the one that we're most interested in is access to pharmacists. And we're adjusting these to per 1,000 people so that we can compare and contrast these different size areas. There's an interesting pattern here between metro, non-metro remote, and non-metro adjacent. Notice that across the board, access to pharmacists, mental health care providers, dentists, primary care physicians are all higher in metropolitan counties. In other words, they're all lower in non-metropolitan. But notice the difference between non-metro remote and non-metro adjacent. The non-metro adjacent, that's the middle bar there, is consistently lower than non-metro remote. What we're thinking here is that even if you live in a rural county, a non-metropolitan county, if you live adjacent to a metro, are you simply accessing the healthcare facilities or the healthcare providers that are in that metro county? But as you move farther away from that metro county, the market is a little bit more robust for having healthcare providers. So again, yes, non-metro access to healthcare in non-metropolitan counties tends to be lower than metro, but when you get into non-metro, there's a little bit more refined story there that actually makes sense. Next slide, please. This is another set, rather than looking at the number of professionals, mental health care professionals, this is kind of looking at different types of businesses, the offices of dentists, a much higher concentration or availability in metropolitan counties. Nursing care facilities, it's a little bit more even, but again, remote non-metro, there's a lower access to nursing care facilities. Home health care services, again, metro tends to be higher. General medical and surgical, these are these general purpose hospitals that tends to be getting a lot of the attention. Again, you can see that access in metro tends to be higher, but it's that particular indicator that tends to be getting most of the attention. Continuing care retirement communities, again, higher access in metro areas. I think that as the baby boomers start to age, I think this access to nursing care facilities and continuing care retirement communities and assisted living, the second from the top and the bottom one, I think is going to become increasingly important, that we have to start spending more time thinking about and worrying about. Next slide, please. Again, this is just simply different ways of looking at access to healthcare. And again, we see the same general pattern here. Next slide, please. So generally, access to healthcare is less desirable in rural areas relative to urban, but that pattern across non-metro adjacent and non-metro remote is less consistent, okay? Are non-metro adjacent counties, are people living in non-metro adjacent counties simply accessing healthcare facilities in those metro counties? It seems to be yes. We need to kind of think about how do we define access from kind of a spatial dimension, and that's something that Melissa and I are working on. Next slide, please. Okay, so for many parts of rural America, access to healthcare is in crisis. Much of the public discussion, again, has tended to focus on rural hospital closures. Hospitals are about one part of the healthcare delivery system. Pharmacists is an integral part, as we'll talk about later in the Lunch and Learn, but it's largely overlooked. In this study, what we're really trying to do is analyze patterns of pharmacies across the U.S. Is there a distinction between urban and rural communities? Hi, Kristen. How is metro defined? Metro is defined by the Office of Management and Budget, and it is having an urban place of at least 50,000 people. and non-metro adjacent counties to a metropolitan core is defined on commuting patterns. So for example, Dane County, where Madison is located, that's a metropolitan county, but you have Iowa County to the immediate west of Dane County and Greene County to the immediate south. If you look at Iowa and Greene County, they are very much rural counties, but because of commuting patterns, they're part of the Madison metro or the Dane County metropolitan area. Okay. So the question that we really want to ask from an academic perspective is, are chain pharmacies pushing out independent pharmacies? We're seeing a pattern within the number of independent pharmacists, and we're wondering whether or not the introduction of chain pharmacies is kind of creating a Walmart effect, if you will, and is creating a competition that is detrimental to these independent pharmacists. Now, if that's happening, and that's the research question, what does that mean? Next slide, please.
So, yep. So first I want to point out the different types of pharmacies. The one that people probably think of the most is community pharmacies. This is where most people go for their prescriptions. There's also pharmacies located within hospitals and clinics and nursing homes, and they'll have a pharmacy or pharmacist on the premises. There's also other types of pharmacies that are in charge of research and regulatory compounding, but we don't directly look at those types of pharmacies in this work. What we look at is the community pharmacies, and what we do is we delineate between independent pharmacies, those that are owned by an individual pharmacist or maybe a group or a cooperative, and then chain pharmacies. So think like Walgreens, CVS, Walmart, those types of pharmacies. And so what we look at in this study is the community pharmacies compartmentalized into independent and chain pharmacies. And so some background on this is that we saw a rash of closures after change in Medicare, where Medicare Part D policy in 2006 expanded prescription coverage to Medicare recipients. But the problem was that it came with really low reimbursement rates for pharmacies. And so this especially impacted independent pharmacies that just had trouble billing out for these services. And part of it was relying on patients that paid in cash. And so this put independent pharmacists at a disadvantage. And there's a great body of work, especially out of Iowa, that looks at the impact of the Medicare Part D and its effect on independent pharmacies. And so this left many rural residents without an access to a pharmacy, so essentially creating a pharmacy desert. And we can look at later when it comes to policy changes, how changing the reimbursement rates can affect how this has kind of detrimentally affected independent pharmacists, but also not allowing for patient counseling as part of the reimbursement process. And then, what we try to explain in this work is the importance of pharmacies. And I don't think people always think of their pharmacies as their place for healthcare, but pharmacists are there to dispense medications, but also make sure medications are safe for a patient, combinations of medications are safe to take. And if you think about, a pharmacist is very accessible to patients. And I know we have pharmacists in the room, and I'm sure you're thinking sometimes, yeah, we're too accessible, because you can just walk into the pharmacy and talk to a pharmacist. And they provide patient counseling. Every time you pick a prescription up, they ask, do you want to speak to a pharmacist? People can pick up the phone and call a pharmacist. So pharmacists are very accessible. You don't typically have to make an appointment. Park close to the door, walk right in. And so people, have a high level of trust too with their pharmacist. They tend to know that person. If you're looking at an independent pharmacy that's located in a small town, you tend to know that pharmacist. But the other thing, the other part of pharmacies and healthcare is that they provide really important preventative services, such as blood pressure checks, glucose monitoring, immunizations. And this helps keep people from needing more costly care. It helps prevent hospitalizations when people can go and have their blood pressure monitored at a local pharmacy. And it can really cut down on the cost of healthcare, such as needing to make a doctor's appointment when you can talk to your pharmacist. And when you think about people living in rural areas that live, 30 or 40 minutes, if not more, from a hospital or even a clinic, having this vital access to a healthcare provider who's the pharmacist is really a key part of our healthcare delivery system. So when people don't have this access, they tend to forego these essential services, this essential treatment, and then this can really compound underlying health problems. And in some rural areas, a pharmacist might be the only source of qualified healthcare that there is, especially as we see the continuation of closure of hospitals or consolidations. And also, people report a really high level of trust with a pharmacist. There was a survey out where people said that they were much more comfortable talking to their pharmacist about a health condition than they were a doctor. Also, again, more accessible to just call that pharmacist or go in instead of making an appointment with a healthcare provider. So this is a piece of work out of the Journal of American Pharmacists Association that illustrates the access to pharmacies in Wisconsin. And if you, Steve had talked about earlier about rural, small town, this adds micropolitan and metropolitan. You can see that the dark orange areas are the rural areas. And then where there's the availability of chain pharmacies, independent pharmacies, or an outpatient hospital that has a pharmacy at that location. And you can see the commuting areas and how far people live from this access to healthcare. And what's interesting is I have another piece of work that Brandon mentioned at the beginning, and there's a map in there that talks about people's access to a Walmart. Most people are like a 30 or 40-minute drive from a Walmart. Well, of course, that's going to correspond with this map because Walmart is a chain pharmacy. People living in a rural area have to commute typically to a larger area for groceries, healthcare, prescriptions, lots of things. And this is another map from that piece out of the Journal of American Pharmacists Association that looks at the drive time to a pharmacy. What's interesting is it says, that most people are within, almost everybody is within a 30-minute drive to a pharmacy. And a lot of people are within 20 minutes. I'll tell you, where I live in Western Wisconsin, I'm not within 20 minutes of a pharmacy. So I guess it just kind of depends too on where you live. But, when I was I was trying to convince Steve about this work. He's like, well, why can't you just drive 45 minutes to the pharmacy? And I said, well, because if my child is sick, the last thing I want to do is drive an hour and a half round trip to get something that's standard like amoxicillin. And I don't think that's unreasonable to want medications available to us, when we're under the weather. So that was how I convinced Steve to partake in this work. And now I'm going to turn it over to him because these are his pretty graphs.
Thank you. What we did is that we actually have access through the UW system to detailed data on individual pharmacies. These are business based. And what we're doing is that we're looking annually from 2011 to 2020. So this is every year over that time period. What we're doing here is just some simple descriptive analysis looking across the urban-rural divide. Previously, we had kind of three groupings: metro, non-metro adjacent, non-metro remote. This is a little bit more refined. From at the top, these are the most rural counties. They have, small communities. They're not adjacent. They're pretty remote. These would be the most rural of rural counties, all the way down to the largest places, counties that have 1 million or more people, the Chicagos of the world. Now, one of the things that what we broke out here is the average number of pharmacies from chains and independents. Notice there's two patterns here. One is that as you become larger, you have more pharmacies, and that makes perfect sense economically. You have more people, market demand goes up, and you can support more pharmacists. That makes perfect sense. But the pattern here that's interesting is that when you get into more rural areas, the pharmacists tend to be independent. They tend to be dominated by independent pharmacies. Chain pharmacies are less likely to go into really rural areas. But chain pharmacies tend to prefer to be located in these larger metropolitan areas. Next slide, please. Okay. Now, this is a mapping. This is an average of 2019, 2020. And we took an average here because you'll see later on something happened in 2020, and that's the year of COVID. Okay. Now, this is the location of chain pharmacies. The darker the blue, the more chain pharmacies we have. You can see some of the metro areas. You can see Chicago popping out. You can see Detroit popping out. You can see the Twin Cities, St. Louis. Okay. But notice the areas that are white, particularly in the Great Plains, from Texas up to North Dakota and Montana, and out into some of the Mountain West. These are counties that have no chain pharmacies. Notice this pattern here. Okay, chain pharmacies tend not to locate in these most remote rural areas. And even when you look at Wisconsin, there are some counties in the northern part of the state, there are no chain pharmacies there. Now, that map that's in the upper left-hand corner, that's just a mapping of that. There appears to be a pattern there. But the question is that pattern really statistically significant? And that's what the analysis in the lower right-hand corner does. Okay, and what we're looking at here is essentially using some mapping software that allows us to look at these statistical patterns. And there's a couple of things that I want to point out here. One is the areas of the U.S. where it's kind of that off-white color. There's no pattern there. The statistics, it's statistically insignificant. There's no pattern there. So much of Wisconsin, there's no real pattern in the data. Okay. The kind of the tannish color are high clusters. What this is that you've got a county that has a high number of chain pharmacies surrounded by counties that have a high number of chain pharmacies. Look at Chicago. You can see much of California. You can kind of see the Seattle area. You can see Miami. Okay, you can see the urban areas of Texas. Okay, the kind of the soft blue are low lows. These are counties that have a low number of chain pharmacies surrounded by counties that have low number of chain pharmacists. Notice the large swaths of the U.S. that are kind of low concentrations. Okay, these red ones, these are kind of urban hubs, or a city, if you will, that has a lot of chain pharmacies surrounded by counties that have low numbers of chain pharmacies. So what we're seeing here is that pattern that's in the upper left-hand corner. There is some statistical patterns here that we can make some inferences from, and there are large swaths of America, particularly rural America, where we don't have a high concentration of chain pharmacies. Next slide, please. Now, if we look at independent pharmacies, okay, look at the upper left-hand corner. Notice that there's still parts of the Great Plains and some parts of the Mountain West where there are no pharmacies. So these counties, they simply don't have a pharmacist, period. Whether it's a chain or an independent, they're not there. You can also see some of the urban centers, but notice that the number of counties that are lacking a pharmacist in terms of independent is much lower. Okay, we still see the same pattern though in the lower right-hand corner of large swaths of America that generally have low access to pharmacies. So yeah, there's a pharmacist there, but there's not a whole lot of them. So between the lack of chain pharmacies and the lack of independent pharmacies, there are large parts of rural America that really don't have access to pharmacies. Next slide, please. Now, this is looking at these changes over time, okay? And we grouped the counties, again, by non-metro adjacent, non-metro remote, and then metropolitan, okay? Now, we've got two scalings here so we can compare. The non-metropolitan is scaled on the left-hand side, the metros on the right-hand side. There's an interesting pattern here. First of all, the average number of chain pharmacies is much higher in metropolitan counties, as we would expect. Is much lower in non-metropolitan remote relative to non-metropolitan adjacent. And that tends to be these remote counties tend to have lower populations. So that's what we expect. But notice this kind of inverted U-shaped pattern. There was growth in the number of chain pharmacies up until about 2017, and then it started to come down. Okay, this is part of the research. We're trying to better understand why we're seeing this decline in the number of chain pharmacies, whether you're talking urban or rural. Now, if you look at the lower right-hand corner, that's the number of independent pharmacies. Okay, again, more independent pharmacies in metropolitan counties relative to non-metro and both remote and adjacent. But notice that there was a kind of a flat period there, and then 2017 to 2019, there's actually a rise, a growth in the number of independent pharmacists on average. But then 2020 hit, COVID hit, and there's a remarkable drop. We're thinking that what this is that many of the independent pharmacists were disproportionately affected by COVID and the COVID shutdown. Because remember that pharmacists, when we think about pharmacists, we think about, prescriptions and things like that. But for a lot of pharmacists, the non-prescription part of the business, okay, is a big part of their business. Okay, they draw a lot of revenue from selling non-prescription medicines and other things. Okay, during COVID, that part of their revenue stream was negatively affected. Okay, so chain pharmacists, it appears, were able to better ride out the impacts of COVID, whereas independent pharmacists got hit harder. Next slide, please. Okay. This is simply looking at the change and what we're seeing here. I'm not going to spend a lot of time here. Between 2011, 2012, 2019, 2020, there's some that are seeing gains. There's a lot that are seeing losses. It's kind of across the board. I think if you look at the Great Plains, there's actually a pretty remarkable decline. You get into the Mississippi Delta region, there's a bit of a decline. We really didn't find any statistically significant patterns with this particular set of analysis. Next slide, please. Okay. Now, one way is to count the number of pharmacies, okay? But when you think about the size of pharmacies, they vary significantly, okay? You could have a chain pharmacist or a chain pharmacy that actually has 4 or 5 pharmacists that are working that. You could have an independent where you may have 1 or 2. So one of the things we wanted to do was to look at the average number of pharmacies per 1,000. Okay, I'm getting ahead of myself a little bit here. What we're doing now is the previous slide, we were looking at just the count, number of pharmacies. Here, we're actually adjusting it per population size. Notice again that even more clearly, when you get into the most rural areas, it tends to be dominated by independent pharmacies. Okay, and as you become more urban, the dependency on independent pharmacies is replaced by greater dependency on chain pharmacies. Next slide, please. Okay. Now, this is where I was going with that, is rather than simply counting the number of pharmacies, we're looking at employment in these pharmacies, okay? With the argument being that some chain pharmacies actually tend to be larger than the independent pharmacies, okay? And that's essentially what we find. You'll find that in the average size in terms of employment for chain pharmacies tends to be much higher than the independent pharmacist that's in the lower left-hand corner or lower right-hand corner, okay? So the chain pharmacies tend to be bigger, Does that mean that they can offer more services? Notice again, we get this kind of inverted U-shaped pattern, growth and then decline. And again, notice that with the independent pharmacies, the effects of COVID is disproportionately impacting these independent pharmacists. Next slide, please. Okay. Average number of pharmacy jobs, we see the same type of a pattern as even when we, whether we're counting the number of pharmacies or we're looking at the number of employment in these pharmacies, we still see the same type of a pattern. Rural areas tend to be more dependent on independent pharmacists than more urban areas. As you move to urban areas, chain pharmacies become more important. So if independent pharmacies are more at risk, rural areas will be disproportionately more at risk than urban areas. Next slide, please. Now, this is going to be kind of academic. What we wanted to do was to see whether or not the presence of a chain pharmacy created downward pressure on the ability of independent pharmacies to work. What we're trying to test is the Walmartization effect, if you will. If Walmart comes into town or other big box retailer comes into town, what does it do to Walmart that you can't compete with Walmart head on? Walmart will essentially has comparative advantage, scale, size, and it's really difficult to compete with a Walmart. What we wanted to do was to kind of test the same thing, but with pharmacies. So what we've got is that we're trying to run a statistical model where we're trying to predict the number of independent pharmacies and the number of independent pharmacies per 1,000 people. Next, go ahead and hit next. Okay. So some of the variables that we want to control for is things like the population employment ratio, all the things that would kind of characterize or describe what the market is for pharmacies. Okay, next slide, please. This is simply a counting of the average annual number of independent pharmacists. This is our dependent variable. This is what we're trying to explain. There is a number of counties. You can see, what is that? About 350 counties that have no independent pharmacists. Those are primarily in the Great Plains. Okay. This introduces a kind of unique statistical challenge that I won't bother you with. But there's also clear spatial dependency in the data that we have to kind of account for. Next slide, please. Okay. Go ahead. Next slide. Next slide. This is the regression equation. Back up. There we go. That one. Nope. Go forward. Go forward. That one. Okay. This is kind of the summary here. Okay. What this is the impact of the number of chain pharmacies on the number of independent pharmacies. This is, we grouped it by all counties. We ran it for non-metropolitan counties. We ran it for non-metropolitan adjacent and then non-metropolitan remote. Across the board, what we found is that negative coefficient. And all of these are statistically significant except for that one, all counties chain pharmacy employment per 1,000 people. Okay. What this is essentially saying is across the board, higher concentration of chain pharmacies pushes out independent pharmacies. So as chain pharmacies come in, much like a Walmart comes in, they have a comparative advantage. And that comparative advantage essentially places the independent pharmacies at a disadvantage. Now, this raises the question of what is the type of services that an independent pharmacist can provide as opposed to a chain pharmacist can provide. And that's something that Melissa is going to spend a little bit more time talking about. Next slide, please.
And that's mine. So whenever we've had opportunities to share this work, inevitably PBMs, pharmacy benefit managers, has come up. And so what PBMs are they're they're intermediaries that work on behalf of health insurers, and they negotiate rebates and discounts. And the pharmacists that I've talked to have said that PBMs are the main problem that we have right now, and that they will direct patients to where they should go for prescriptions, and it's not always the most low-cost option nor the most convenient option for patients. And we'll look at some policy implications later. Also, during COVID, telehealth became very popular. So if you think about, maybe some aspects of healthcare can be done, via Zoom, but prescriptions are a tangible product. So somehow you have to get anything that's prescribed in that telehealth appointment actually to the patient. And so one of the other things that has really expanded is prescription drug delivery from big companies like Amazon and Mark Cuban has a cost plus drugs. And so people will say to me, well, what about prescriptions by mail? And here's the thing. If it's a medication that you take all the time, like, blood pressure medication, it might be an attractive option to just have that mailed to you. And I will say the pharmacists I talk to will point out to me that they've always offered prescription by mail services. Many of them offer delivery services as well. So this isn't something that's new. It's just you have these larger companies like Amazon coming in and acting like it's this brand new service. And so it's fine to have prescriptions by mail when it's something you can expect. But if it's something you want immediate relief from, I use the example of the amoxicillin, you don't want to wait days. Also, there are some prescriptions that cannot be delivered through the mail. Some are restricted, some require refrigeration. And so it's just not feasible at this point to expect that any and all medications can be mailed to us. The other piece that we did look at in that article for choices was pharmacy graduates. So when people graduate from college, this is not just it applies to people other than pharmacy students too, but younger people tend to want to live in more urban areas, and moving to a rural area is not always the most attractive option for most students who just graduated. Salaries lag behind in rural areas, and my challenge in attracting like a rural workforce to my area is trying to explain to them that yes, the salary might be lower, but also the cost of living tends to be lower. But if you look at the compensation for pharmacists in a rural remote area, it's about $126,000 a year versus almost $150,000 in a metro county. And when we look at student debt ratios, that's really important. Pharmacy students graduate with a lot of debt. And so the first thing that they're going to think of once they graduate and find a job is how much is that job going to pay as they start having to pay back their loans. Pharmacy students graduate with an average of $179,000 in student debt. It's very high. And my distinguished colleague, Dr. Deller, also did some work on how high student loan debt is a deterrent to entrepreneurship. Because if you think about, if you've just graduated from college and you have a lot of student debt, the last thing someone probably wants to do is to take out a loan to start a business. And that's really what it means to be an independent pharmacist, is you're a pharmacist, but you're also a business owner. And to couple that much debt, you can see how pharmacy graduates would be adverse to that. However, pharmacy students who are from rural areas are more interested in pharmacy ownership than other students. And this could, legacy students could account for this too, those who, have parents or grandparents who are pharmacists, more likely to go to pharmacy school and want that type of business. Also, student surveys showed that student interest in owning their own business is higher when they enter pharmacy school, but that interest will wane if they don't have an opportunity to do internships in independent pharmacies, especially those in rural areas. And so some of the challenges that we face in rural areas in general is succession planning. So anywhere from taking over farm businesses to pharmacy businesses, it is hard to get a new generation interested in business ownership and wanting to take on a business. So, if we can attract workers to rural areas, but also get them interested in business ownership, that can, help stabilize the independent pharmacies that we have, maybe even some new ones. Part of the research that we did, I had talked to some researchers out of University of Minnesota who look at consolidation. So independent pharmacies consolidating with a larger healthcare system, because that can help alleviate some of the overhead costs and administrative burdens that come with running a pharmacy business. And one pharmacist that I talked to just had an opportunity to take her downtown business and merge with a hospital that was being built, and it was kind of like one of those, like beat them or join them type situations, and so that turned out to be a positive thing for her. Sometimes that type of move can help an independent pharmacy, especially when you're looking at challenges with reimbursement rates or low reimbursement rates. One thing to consider too is expanded student loan forgiveness program. There's about 10 states that offer student loan forgiveness for pharmacy graduates who locate to rural or in other underserved areas. And that is certainly something that we could look at here in Wisconsin if we want to incentivize having recent pharmacy grads move to rural areas. There's also some other key policy changes that could happen, such as pharmacists being able to fully bill for patient counseling services. There has been some restrictions on pharmacy benefit managers. There's some bills pending right now too, I believe, but maybe some looking at the regulatory part of pharmacy benefit managers, especially in how they do the rebates and the discounts, and whether that really is the best situation for the patient, are all policy changes that can be looked at when we're trying to, just make it a fair playing field for all the pharmacists. So with that, I think there are some questions. Steve, is there anything you wanted to add while I switch over to the chat?
I think that you mentioned the succession planning. There's some research that was done by colleagues at Purdue University, Iowa State University, and North Dakota State University that looked at some rural communities in the upper Midwest, in the Midwest that were doing particularly well from a retail perspective. And one of the things they found was these communities had pretty active succession planning type programs. Essentially, many rural business owners, when they decide to retire, they just shut the business down and they don't even think about selling it. And I think that one of the strategies that rural communities could be thinking about is that as you have your independent pharmacies, is work with them and work with the local pharmacy schools, excuse me, to be strategic in terms of succession. And that applies not only to pharmacies, but other businesses in rural communities. I think that's an interesting strategy that pharmacist communities could be taking. Can we just open it up to general conversation now?
Yes, for sure. And thank you, Melissa and Steve. If there are any questions that folks have, please feel free to either drop it in the chat or you can unmute yourself and ask a question. And Marie, I see you have your hand up. We can't hear you, Marie.
Can you hear me now?
We can, yes.
Yes.
I apologize. I'm curious if in any of your research you came across any data or information about telepharmacies. One example, one of our hospital's affiliated clinics in Elroy, Wisconsin, had an independent pharmacy closed years ago. And when they built a new clinic in the community, they put a telepharmacy inside the clinic. So it has a remote pharmacy or a pharmacist essentially, but then they can dispense locally. Has there been any research?
We didn't specifically include it in our research, but I mentioned this, but most of the independent pharmacists I talked to said, we've always done that. We have always provided prescriptions by mail. We've delivered them. So it wasn't necessarily wasn't packaged differently, just that's a service they already offered. In fact, they would tell me stories about how people would call them in the middle of the night for something, even something that was over the counter, and want that kind of personalized service, but not anything. I don't know, Steve, nothing specifically about telepharmacies.
No, I think though that as we build out the rural broadband infrastructure and people become, one, they have access to broadband in a way that they hadn't really before, and they become more comfortable with it, I think that we need to start looking at all options for making sure that people have access to care. This could be access to mental health counseling, could be access to a pharmacy, but we still have the problem of the physical delivery of the prescriptions. And as Melissa said, for some things, I mean, if you're on high blood pressure medicine, getting that through the mail may work, but it's these, you got a sick kid, okay, and you need access to it. I need access to it now. That's different. The other thing too, and I feel less comfortable about this, is that personalization of services that you get with an independent pharmacist that you may not get with a chain pharmacist. I've noticed that my own personal experience here in Madison, I go to an independent pharmacist. They know me. My wife goes to a chain pharmacy. It seems as though every time we go in there, there's a different pharmacist behind the counter. You can't build that personal relationship. And I'm not sure, as a researcher, I'm not sure how to go about quantifying that and measuring the so what element of it.
And one thing I didn't mention was, COVID-19 was particularly hard on pharmacists because they did play such a key role during the pandemic. They were really instrumental in rolling out with the immunizations, but also they report and are continuing to report like really high levels of burnout, just because trying to keep up with the demand and then also providing like a personalized service. And if you think of a chain pharmacy where there's backup pharmacists, or they'll just close the pharmacy over the noon hour, an independent pharmacist doesn't usually have that luxury of having somebody take over for a vacation or even a lunch break. And so I think they're really feeling the stress of not having any relief to their workload, on top of, providing and I guess expecting to provide at times a really personalized high level of care, and just, where's the relief in that for them?
And that's an interesting point because, we spend a lot of time thinking about student debt and repayment of student debt and whatnot, but this, being your own boss and owning your own business has certain positive externalities, if you will, but there's also a lot of, it's not easy. It's hard work. And if you're coming out of pharmacy school and you're being offered a job at a chain and you're being offered benefits, perhaps a pension plan, and you have set hours. An independent pharmacist doesn't have that. So there's a yin and a yang there that is really. There was an interesting study a number of years ago asking dairy farmers in Wisconsin why they decided to get big. And everybody thought it was purely economics. They could make more money. Nope. The overriding reason is that they said the only way to get time away from the farm, to have family vacation and whatnot, is we got to get big enough that we can hire help. So the motivation to get bigger was simply to have greater freedom. That kind of, how can an independent pharmacist get into that kind of situation? They have to be of a certain size. Otherwise, they're on call 24/7.
Steve, Melissa, I just wanted to thank you both for this great presentation. So my name's Ed Portillo. I'm a pharmacist. I teach at the pharmacy school actually in Madison, and I have the privilege of coordinating our rural health program for students at UW. And it was refreshing to listen to this. I agree that often when we talk about rural healthcare, community pharmacists, despite on average, patients living within a 5-minute drive to their community pharmacy are overlooked. And yet we provide such critical support for rural communities. So I just wanted to thank you for, really focusing in on this, and just wanted to share something kind of neat, which is the data, those maps you shared actually were made by our students at the pharmacy school as part of our rural health program for PharmD students. So I just wanted to highlight that, like, those data points are, budding pharmacists who are really interested in rural made those. And it is just so neat to see. The spotlighted. I'll just throw one more article in the chat. This was just published looking at pharmacy services in Wisconsin. And there's a huge gap, like you said, between what pharmacists are doing in rural communities and just the complete lack of reimbursement, which then makes it difficult to stay in business, right? And so just want to include that as well, and just thank you for everything.
And I was just going to tell you, I'm like, you're cited in our work. I know your name.
Yeah, I mean, the students let me tag on the end of their paper, but it's all our students, and there's a ton of motivation. It's just making sure that our rural pharmacists are able to stay in business and be reimbursed for providing these, chronic disease management services, for partnering with physicians and, nurses and others in the community to really serve as part of that medical team. So it's been, it was great listening to your presentation. Thank you.
Thank you.
Thank you,
And
Ed.
I also didn't mention this fully, but there's the spread on dispensing medications is very slim, like pennies sometimes. So there has to be something that changes with this.
Ed, though, your study, we were building some of our spatial analysis, and then your paper came out, your Wisconsin paper came out, and Melissa sent it to me, and she said, "Can you do this for the nation?" And I just went, no, I don't know. I should talk to your student to figure out how to do that.
Yeah.
Oh, goodness. Well, we partnered with the Office of Rural Health for the state, and it was a great partnership. And, the cool thing about the paper I put in the chat is that sort of takes some of those pharmacies, and we asked, like, what are the services you're providing? And there's just a huge list of services that pharmacists are providing for rural communities, and with minimal to no, actual reimbursement to keep them open, which is really tricky.
Mm-hmm.
Thank you, Ed.
I saw there was a comment in the chat too about transportation, and I don't know if I mentioned this either, but if you think about people who are most likely to have high rates of access to healthcare, those are typically the people who also have barriers to transportation. So those people who are older, people living with disabilities, needing more access to healthcare, and then finding transportation a burden, especially in a rural area where you have to drive 30 or 40 minutes to just a general healthcare provider.
So I don't want to squash conversation, but I do want to be respectful of everyone's time. And again, I want to say a big thank you to Melissa and Steve for taking this lunch hour to share your work. So you have it, and this will come out in a follow-up email. This is where the presentation notes, additional resources, and the recording will be posted online. So with that, I just want to say thank you to everyone for joining us today, and I hope you have a wonderful day and a wonderful week. Take care.